The first question I will direct is to Erin. Erin, with frail older adults, is there a benefit then to using combination insulins to avoid injections of longer acting ones like Lantus?
That's an excellent question. In terms of a starting point for type 2 diabetics, usually we would recommend just starting with a long-acting insulin to minimize the total number of doses of the total daily number of injections, and as well to simplify monitoring. However, if that's not sufficient to control blood glucose, then certainly adding on mealtime insulin is appropriate. Because mealtime insulin will cause a more pronounced spike in blood sugar and then cause the blood sugar to come down slowly after a meal. It does predispose patients to hypoglycemia if they're not eating regularly or properly but still taking their insulin. As well, people often don't like to take multiple daily doses of insulin by injection if they don't have to. So usually from the preferences side, going with a long-acting insulin alone first is ideal, but again, adding on a short-acting insulin if needed. I hope that answers your question.
Thank you, Erin. Another question that has been asked is of Karen. Karen, is there a charge for calling MedSask?
No, there isn't. We're funded mainly through the government and the College of Pharmacy Professionals, and we're a nonprofit organization, and we provide our services at no charge either to healthcare professionals or to the general public. Thank you for the question. I'm glad you asked.
Thank you, Karen. The next question that's come in is back to Erin. Erin, what guidelines does a physician consider when starting a patient on a direct oral anticoagulant? The person who asked the question said if they remember correctly, they come in a 1-tab dosing, unsure of the milligrams, but they don't remember seeing more than 1 tab being given regardless of the size, the creatinine clearance. Because of this, is the dosing given on these direct oral anticoagulants an issue when switching from warfarin?
Okay, so I'm going to take a stab at answering your question, and then feel free to text back if I didn't get at what you were looking for. So in terms of where to look for information on switching from warfarin to the new oral anticoagulants, there's many different resources you can use, including Lexicomp, and the RX Files as well has some good information on dosing for the new oral anticoagulants, when to look at dose adjusting the new oral anticoagulants, and then how to switch either from warfarin to one of the new oral anticoagulants or from one of the new oral anticoagulants back to warfarin. In terms of milligram strengths, you're right, you would never need to give more than 1 tablet at a time. However, the various new oral anticoagulants do come in some different strengths. So the dabigatran or the Pradaxa comes in both a 150 and a 110 milligram strength, and it would be given twice a day. And guidelines for dose adjustment are mainly centered around renal function. And again, that information you can find in the RX Files. Apixaban is also a twice-a-day dose, and it would be either a 5 or a 2.5 milligram tablet that would be given twice a day. And again, dosing adjustment is necessary for renal dysfunction and older age or low body weight. And then with the rivaroxaban as well, rivaroxaban is a once-daily dose, and it comes in either a 20 or a 15 milligram strength. And the dose adjustment, again, is around renal dysfunction. And so I'm speaking here specifically to the indication for atrial fibrillation, so not looking at venous thromboembolism prophylaxis or treatment, but those would be the atrial fibrillation doses. So I hope that answers your question.
Thank you, Erin. The next question is for Karen. Karen, should we call MedSask with poison control questions?
No. Poison is another very specialized area of drug information. PADIS, the Poison and Drug Information Service in Calgary, has the contract for poison information in Saskatchewan. So if you suspect a poisoning, you should call that number direct. It's, I should have given it to you on the handout, but it's 1-866-454-1212. So probably a number you should have posted up where you have easy access to it. Thank you.
Thank you, Karen. And what resources does MedSask use to answer questions?
Well, we use quite a few resources, obviously. We're at the University of Saskatchewan, so we have access to all of the library resources there. In addition, we subscribe to Micromedics, which is a very large drug database. We subscribe to the medical guidelines up to date, and also to Pharmacist Letter. And I believe the same company that puts out Pharmacist Letter is now going to put out a Nurse's Letter as well, too, so you might want to watch for that. It's an excellent resource that provides a monthly newsletter which very succinctly summarizes all the latest developments in drug information. As well, working at the College of Pharmacy and Nutrition, we do have access to some of the faculty there as well and their expertise in various areas. We very frequently use the RX Files drug comparisons. It's an excellent resource as well. And that's all I can think of at the moment, but we do use quite a wide variety of resources in order to provide answers to our callers.
Thank you, Karen. We have a question from the studio audience here in Saskatoon.
Hey, is there a difference in the efficacy between like Xarelto and then the BID dosing oral anticoagulants? Is there a really big difference there at all?
That's an excellent question. Rivaroxaban or Xarelto is once daily dosing, and that's because that's how it was originally studied in the Rocket AF for the pivotal trial that compared rivaroxaban to warfarin. And so in terms of its effectiveness compared to the other direct oral anticoagulants that are twice daily dosing, as of yet, there's no head-to-head studies between any of the direct oral anticoagulants. So this is all looking at data that compares the direct oral anticoagulants individually to warfarin. However, rivaroxaban was considered non-inferior to warfarin in the Rocket AF trial. So it's even though it's a once daily dose, it's at least as good as warfarin is. However, that being said, both dabigatran, the 150 milligrams twice a day dose, and apixaban, the 5 milligrams twice a day dose, actually showed a little bit of benefit over warfarin for venous thromboembolism prophylaxis. And so from that perspective, because they did actually show some superiority in those trials, it's possible that they are more effective than rivaroxaban. The other issue that has recently come out with rivaroxaban is around the Rocket AF trial, and particularly the INR monitoring device that they used in that trial has since been recalled for giving false readings or unpredictable readings. And so that's kind of called into question the results of the Rocket AF trial and their validity. If warfarin was either underdosed in patients, it could make rivaroxaban look falsely better for either efficacy or bleeding. And so those are kind of questions that are still being sorted out, and that's all fairly new. But since that has come out, that's kind of shied me away from rivaroxaban or Xarelto for those reasons. And like I already said, I'm not a big fan of dabigatran for older adults, so I usually default more to the apixaban. But as it stands from what we know right now, it is at least as good as warfarin, so it is still a reasonable option.
Thank you.
Thank you, Erin. Karen, for MedSask, do you provide services in Lloydminster? Because it's a border city, sometimes the patients would have Alberta Health Services numbers instead.
Yes, we do, actually. We do take calls from outside the province. often not a lot of people call because they're not aware of the service, but we do get calls from students that are working in Alberta or Manitoba or other provinces, and we take their calls, even though technically speaking, I guess we shouldn't, because it's the Saskatchewan taxpayers' dollar that's paying for the service, but we don't refuse to give information to anyone.
Thank you, Karen. Erin, in regards to cardiac medications, is the new research to give them at bedtime?
So I'm assuming that's cardiovascular medications in general, but again, let me know if you're wondering about something specifically that I don't answer. A lot of the reason for dosing some of the cardiovascular medications at bedtime is kind of theoretical. So we're often told to tell patients to give statins at bedtime because our body manufactures most of our cholesterol at night while we're sleeping, and so theoretically maybe statins are more effective at bedtime. But there's never been any studies comparing statins dosed at bedtime to statins dosed at any other point during the day. And I think really the most important thing is for patients to take medications when they're going to remember to take them. So if a patient is more comfortable taking all their medications first thing in the morning versus trying to remember a bedtime medication, I would say that that's perfectly fine, and that's a lot more important than the time of day that the drug is taken. I'm trying to think of any other instances where taking a cardiovascular medication at bedtime would really be necessary. And honestly, I can't. Blood pressure medications, it's generally fine to take them at any point during the day. Sometimes we will recommend that patients space out blood pressure medications, particularly if they're having kind of fluctuating blood pressures where their blood pressure is going high or low. But in terms of effectiveness, they're no more effective taken at night. Diuretics specifically, we would recommend patients take them in the morning so they're not getting up at night to go to the bathroom. And I think actually from my grandma, I heard that Dr. Oz had said something about taking aspirin at bedtime and how that's better. And then my grandma was terrified because she'd been taking her aspirin wrong all of these years. I love Dr. Oz. But really, again, evidence-based. There's no evidence that taking aspirin at bedtime versus in the morning is better. And because aspirin is such a long-acting medication, it really doesn't likely make any difference. So I hope that answers your question, but if there's something specific you are wondering about, then please text back and let me know.
Thank you, Erin. The next question is directed at whoever would like to answer it. When you have an elderly client in long-term care and on an MDI and not controlled blood sugars, what amount of testing do you recommend?
Okay, well, I'll go first, and then
Yes,
you can
please.
feel free to jump in and add anything that you feel I've missed. So that's a little bit of a tough question. I guess it depends for what reason their blood sugars are uncontrolled, if it's blood sugars that are too high versus too low. So again, blood sugars that are too low, you'd want to test fairly frequently until you can get rid of the lows, because preventing hypoglycemia is of huge immediate importance. Hyperglycemia, I guess it depends again how high the blood sugars are going. A lot of older adults can actually tolerate fairly high blood sugars, particularly in the short term. So I wouldn't be, terribly concerned with checking blood sugars a ton for blood sugars, even up to 20 millimoles per liter. And again, work at just slowly titrating down. It also depends a little bit what kind of regimen they're on. So if they're on like a basal bolus or just a long-acting insulin, that would affect how often I would check as well. For your hypoglycemic patient, if that's what the issue is, then I'd recommend checking before every meal, so before breakfast, before lunch, before supper, and before bed, until you can get rid of the lows fairly consistently. If hyperglycemia is the issue, then again, I guess I would recommend checking before or after meals and trying to establish a pattern and then going from there. And then hopefully for patients in long-term care, I really wouldn't want to subject them to a ton of blood glucose monitoring on an ongoing basis. So trying to resolve whatever the acute issue is. And again, ongoing hyperglycemia up to about 14 or 15 in a long-term care patient isn't really something I would be terribly concerned about. And hopefully I'd be aiming to just monitor blood glucose 1 to 2 times a day, kind of max would be my thought on that. I don't know if you have anything to add, Karen, or any further comments.
You did a very comprehensive job.